Electrical storm basically refers to a state of electrical instability. I mean, there is a generalized myocardial electrical instability. There are various definitions to define an electrical storm. Maybe we can consider multiple episodes of VT, multiple episodes of VF within a relatively short period, typically 24 hours. However, incessant VT is a little different. It is a hemodynamically stable VT, which is lasting for longer than 1 hour. And in patients without an ICD, the electrical storm has been defined as occurrence of 3 or more hemodynamically stable VT within 24 hours, or a VT which recurs within 5 minutes of termination, sustained or non-sustained VT, which results in total number of VT beats or ventricular ectopic beats that is greater than total number of sinus beats in a 24 hour. So basically, I mean, that's what I was saying, that in all these definitions, it is basically a generalized myocardial electrical instability, which is the underlying theory. And in patients with ICD, the most widely accepted definition is 3 or more appropriate therapies for ventricular tachyarrhythmia, including ATP or shock within 24 hours. So basically, the actionable definition of an electrical storm is 3 or more episodes of ventricular tachyarrhythmia in 24 hours. However, this definition does not include a patient who has a VT that is slower than the programmed detection rate of the ICD, or a VT that fails to terminate with appropriate ICD therapy and remains undetected by the patient, an incessant VT which is slow and not much symptomatic, a VT that recurs soon after successful therapy may remain undetected because of the slower rate, may not fall into the VT categories. So when we consider an electrical storm or a VT storm, what we see is that in around 85 to 95% of the cases, it is caused by a monomorphic VT. In a way that is for the good only, because monomorphic VTs are more amenable to definitive therapy. VFs in different series can be present in 1 to 21% of cases, and VT-VF in 3 to 15%, polymorphic VT in 2 to 8%. And this meta-analysis published in Europace, it shows that the hazard ratio is around 3.15 in patients who present with an electrical storm. So definitely, as we all are aware, that presence of an electrical storm significantly increases the mortality of these patients. So I'll just skip all those routine etiology part and all, because we know that VT electrical storm is caused by the electrical storm is caused by dyselectrolytemia like hypokalemia and hypomagnesemia. So those are the correctable causes that we can take care of. We should try to correct the hypokalemia, and the target potassium in patients who have ventricular arrhythmias is on the higher side, and target should be between 4.5 to something around 5.5, and the magnesium should be maintained more than 2.5. Then some thyrotoxicosis is sometimes missed. So all such patients should be getting a thyroid profile, including a TSH. Urinary drug screening can be done if a relatively young aged person presents with a VT or electrical storm. Then coronary ischemia is the common cause, as in everywhere in the world, it is a common cause of electrical storm. So coronary ischemia should be evaluated and treated emergently. Once these correctable causes are taken care of, then comes the support, because what we have seen is that electrical instability mostly presents with serious underlying heart disease. Most of these patients have serious structural heart disease. And the problem is, the most common therapy that we start is inotrope to maintain the hemodynamics. However, inotropes are known to worsen electrical stability. So as when it comes to hemodynamic support of these patients, the inotropes should be coming lower down in the preference. Our first preference should be non-pharmacological or mechanical circulatory support. And the most readily available is IABP. So intra-aortic balloon pulsation should be immediately instituted when a patient has LV dysfunction or heart failure and presents with significant electrical storm. Then ECMO also is available now in many centers. Post-COVID, many centers have ECMO. So ECMO is another option. Impella is very available in very few places in India. And also Impella is not that much favored because the Impella catheter might itself be proarrhythmic in these patients because of the general irritability of the myocardium. So the point here I want to stress is that inotrope should be lower down, and the mechanical circulatory support, at least an IABP, should be immediately put to support these patients. Then next, another very important aspect is sedate. So sedation is available in the form of, we can give oral benzodiazepines, we can give Dexmed, opioid analgesics, and lastly general anesthesia. There was this very interesting paper published in Circulation where they have actually done a detailed analysis of the deep sedation in patients who present with electrical storm. And there was interesting finding that Dexmed was actually found to be superior to propofol and somewhat superior to morphine. So this is an important observation because Dexmed, especially in some of the hospital settings, it is very difficult to get morphine. However, Dexmed is a better choice in such patients, and Dexmed is readily available in most of the pharmacies. We can give a bolus dose of Dexmed that is 0.5 microgram per kg bolus, and which can be followed by 0.5 microgram per kg per hour infusion, and can be increased to 60 microgram per hour infusion. And that gives a good level of sedation without causing hemodynamic compromise, without causing much of respiratory compromise. So Dexmed should be our preferred sedative in such patients. So that's what the first three things we should do is we should try to correct the correctable causes, then we should try to support the circulation, and we should try to sedate the patient. So that will give the initial stabilization of these patients. And what this, again, the same Circulation papers comes up with a very interesting figure that in patients where we are able to achieve deep sedation within 15 minutes, we see acute termination in a majority of the cases, and there is a 55% lower risk of in-hospital mortality in such cases. So that tells us about the importance of deep sedation in such patients who present with significant electrical instability or electrical storm. And when there is no acute termination after deep sedation, we can consider hemodynamic support, mechanical circulatory support, neuraxial modulation, or urgent catheter ablation. Once we achieve the initial stabilization, then the step 2 is evaluation. So after stabilization and patients who present with unstable pulseless activity, they should be stabilized with the ACLS protocol. And after that, most of these cases, majority of these cases will have structural heart disease. If structural heart disease is not there, then we have to evaluate for specific subgroup. Specific subgroups are a totally different ball game because they have the genetic arrhythmia syndromes and all. They are rare and they present a different category of problems. However, our most common category of patients are patients with structural heart disease. And when the patients with structural heart disease, what we have to see is whether there is an active low output state, or there is, if the active low output state is there, like patient is having reduced urine output, or on the ABG we see that the lactate levels are increasing. The mental status we cannot assess because we already have sedated these patients. In those cases, our priority should be to aggressively support hemodynamically to such cases. That should be the priority before we go into other therapies. So hemodynamic support is most important when there is a active low output, because once there is a low output state, the vicious cycle actually sets in, where any further events will again further lower the cardiac output, will cause more myocardial stunning, and ultimately the outcome of such patients becomes very worse. So that's why if there is any evidence of active low cardiac output, we should go for an aggressive hemodynamic support. And once we have taken care of that, next part comes the medication, the devices. Why device troubleshooting? Because ICDs have a survival bias. What happens is, most of these patients with electrical storm, they may not survive up to the hospital emergency. So ICDs, they definitely do not take care of the electrical storm. However, they help the patient to survive till they get in contact with the healthcare system. So basic medical therapy usually consists of propranolol. There was a meta-analysis published in, I think, JACC in 2018, where it was compared that propranolol, oral propranolol 40 mg 6 hourly versus metoprolol 50 mg 6 hourly. Metoprolol for 50 mg 6 hourly is also very high dose in such patients. And it was found that propranolol was far better when it comes to free from electrical storm or in hospital mortality or hospital discharge rate. Amiodarone is definitely the most broad spectrum antiarrhythmic available, and the dose that we usually practice in PGI, that is the standard dose, like 150 mg given slow IV over 10 minutes, followed by 1 mg per minute for 6 hours, and then 0.5 mg. Xylocaine, lidocaine can be given 100 mg to 150 mg bolus, followed by 1 to 4 mg per minute. So these are the standard therapy, and this is the JACC article where we see that there is a survival benefit with propranolol as compared to metoprolol. Once these antiarrhythmic drugs are instituted, and since many of these patients will be having devices, we need to look into the device also. So this table is a busy table. There is no meaning. This is just the standard programming parameter that is given by all these companies. However, when a patient presents with electrical storm, we just have to change these programming parameters. Some of these programming parameters need to be altered, reprogrammed. So few of the programming parameters that should be considered is, we should try to set a higher heart rate threshold. Usually, this is an observation. This was an article published. It is a relatively old article. Still, the observations are very relevant. Usually, patients treated with primary prevention ICDs, they tend to develop fast VT. So such patients may benefit from a higher rate detection zone. So the detection zones can be programmed at a higher rate in such cases, primary prevention ICDs. And patients who are treated with secondary prevention ICDs usually have a slower VT. However, there is a wider overlap with supraventricular arrhythmias. So they can have a slower rate detection zones, but we should give more stress into the SVT discrimination algorithms in patients who have a slower, who have a secondary prevention ICD. So 3 trials like the PREPARE, the MEDITREAT, and PROVIDE, they provide us the information that higher detection zones reduce ICD shock without causing increase in syncope or death risk. Just for our reference, everybody, all of us are aware of this. However, just for a quick reference, this was the MEDITREAT protocol, and what we see in the MEDITREAT, this is the conventional arm, and the high rate arm is that up 170, the zone 1 is the monitored only, there is no therapy, and zone 2 more than 200, there is a 2.5 seconds delay, then ATP and shock. And zone 3 is, arm C, there was 170 at rate of more than 170, the delay is 60 seconds before institution of therapy, and then the rhythm ID detection, enhancements, ATP, shock. Zone 2, 200, there is a delay of 12 seconds, whereas in the conventional programming, the delays are usually 6 seconds, 2.5 and 1 seconds. And here, the programming, the detection delay is increased, and this was shown to reduce the number of shocks without increasing mortality. or without increasing in the number of syncope. And all the different companies trials that different brands that have been tried in all these trials, there it has been shown, to summarize just, that the higher rate cutoffs and longer detection intervals, they have resulted in lesser number of shocks, and they have resulted in they have not resulted in excess mortality or syncope. Then ATP therapies can be programmed in the when we do the interrogation for such patients, and as ATPs can terminate regular BTs up to maybe 300 with 75% efficacy and 94% efficacy with 3 ATP trains. And ATP should be programmed for rates at least up to 250, and below that rate maybe we can program a separate zone. And above this rate threshold, the ATP should be there. I mean, there should be ATP during shock. During shock charging, sorry. So these structural heart disease evaluations and medical management and device programming as the initial part. Then let's talk a little bit about the specific subgroup which we sometimes encounter, like long QT syndromes. They can present with a electrical storm, and usually the standard therapy is, if the genetics is known, it's okay. If the genetics is not known, then beta blocker. There is pacing if there is a bradycardia induced VT, toxin evaluation, then sympathetic blockade. And if the genetics is known, we can give specific therapy like flecainide for long QT3. Then idiopathic VF, usually they are the worst kind of VF. I have one case, I will show that, where most of the drugs, sometimes they do not act, like quinidine, then sympathetic blockade, and PVC, if it is, the storm is triggered by a PVC, that is one of the rare incidences where it can be curable. If we ablate the PVC, then we can take care of the idiopathic VF. Some of the other escalation therapy that have been tried, personally I have never tried ibutilide, but there are reports that ibutilide has been tried, and the number of shocks 24-hour post ibutilide, I mean the number of shocks 24-hour before ibutilide was something like 35, 11, 15, and post ibutilide the number of shocks have been significantly less, either 0, 1 or 2. And the number of doses given ranges from 2 to 9 doses, 1 milligram. I'm not sure about the gap, at what intervals they have given those doses. But this is a very interesting finding, because so far our knowledge was that ibutilide is given for paroxysmal atrial fibrillation, but it can be tried in patients with electrical storm, which is not responding to our conventional drug therapy. Neuromodulation, we know that the stellate ganglion blockade is a effective therapy in patients, especially with refractory VTVF. And in my hospital setting, we have a pain consultant who is a consultant in pain therapy, and he usually does these ultrasound guided stellate ganglion blockade, especially on the left side. It's not a permanent blockade. What they do is a temporary block, and then like all storm passes, so electrical storm also usually subsides 48 to 72 hours. So that gives us a lot of time to stabilize the patient and to tide over the crisis. So neuromodulation is an important part in these patients who are refractory to the first and second line of therapy. Then thoracic epidural anesthesia has been seen, and as we see from this paper that was published recently, that VTVF episodes after thoracic epidural anesthesia has significantly come down, almost to 0. So that's remarkable actually. I don't know, I have no personal experience, I've just read this paper, and there is significant reduction with of VTVF episodes after thoracic epidural anesthesia. So we can always take help of our anesthesia colleagues in refractory cases. Then renal artery denervation has also been tried in some of these refractory cases, and the clinical outcomes, that short-term ventricular arrhythmia recurrence rate have come down to a very low level. Long-term arrhythmia-free survival is something maybe 10%. All-cause mortality was also reduced. So, and there are some reports that, there are some reports available, there are data or evidence is available that renal denervation therapy might actually work in refractory cases by reducing the sympathetic tone, the overall general sympathetic tone of the body. Similarly, stereotactic body radiation, I would like to hear others' opinion about this, because I don't know whether this therapy is available in India or not. However, this paper is from the United States, where the stereotactic body radiation, the stereotactic radiation therapy has been shown to be very effective in such cases, and there is a reduction in the number of device-treated VTVF episodes in these cases. Now comes the catheter ablation. Catheter ablation is like one of the final frontiers of this therapy. However, we have to achieve a certain degree of hemodynamic stability, a certain degree of stability to these patients, because as we know that catheter ablation is a lengthy process. It takes some time, and the patient has to be in the lab for a longer time with so many other complications. That's why ideally we need to achieve some degree of stability before we take up the patient for catheter ablation. And factors that favor ablation are the monomorphic VT, because those VTs are sometimes easy to localize, relatively easier to localize and ablate. We can go for a channel ablation, we can go for a scar homogenization, we can go for a border zone ablation, pore isolation. So many strategies are there. Underlying ischemic cardiomyopathy is more responsive to catheter ablation rather than non-ischemic cardiomyopathy, because as we know, the non-ischemic cardiomyopathy, the substrate for ablation will be more patchy and more diffuse in distribution, endocardial, epicardial, patchy substrates. Whereas in ischemic, we get one transmural infarct with some border zone and some low voltage areas in the border zone, some islands may be there. Unifocal PVC-induced arrhythmia is relatively, safer and relatively easier, because we have to localize the PVC and ablate. It helps that the, when the arrhythmia storm has settled, but there is a risk of recurrence. So once the arrhythmia storm is settled, we get certain degree of stability, and then we can take up the patient for reducing the number of recurrences. Some studies are available to show that there is a role of catheter ablation in electrical storm, especially in electrical storm. The number of patients are not great number. Most of these series are small and reporting some 20 to 50 cases. A few large series have been reported, and all of these cases have included patients with LV dysfunction. And in the acute suppression of the electrical storm, what we see is that up to 100% of the patients, they can achieve acute suppression, and the lowest reported success rate is around 50%. So, in a good amount of, in majority of the patients, we can get an acute suppression of electrical storm with catheter ablation, and recurrence rate, like all VTs, all scar VTs and non-ischemic VTs, the recurrence rates ranges from something around 25 to 50%. However, the recurrence of electrical storm definitely goes down. VT might recur. However, the chances of again developing an electrical storm is significantly lower with catheter ablation. And based on these findings, catheter ablation is a patient who had just died over the storm should be strongly considered. Then this was one of the large trial published in NEJM. Everybody might have gone through this, the Vanish trial. However, it was not a specifically trial of electrical storm, but this was a trial where it was shown that in patients with ischemic cardiomyopathy and an ICD who had ventricular tachycardia, catheter ablation was associated with a lower rate of death, ventricular tachycardia storm or ICD shock at around 2.5 years of follow-up, as compared to escalation of drug therapy. So probability of event-free survival, probability of overall survival, probability of appropriate ICD shocks and lower appropriate ICD shocks and VT storm was significantly low with catheter ablation. So that gives enough proof to consider catheter ablation in these cases. And in the subgroup analysis, we see that in most of the subgroups, whether age, sex, and rate of VT, then functional class, in most of these subgroups, even ejection fraction, the catheter ablation was found to be better than dose escalation. And this trial was, it was kind of an important trial. And based on this trial, the 2017 guidelines of catheter ablation of ventricular tachycardia also gives a class 1 recommendation for catheter ablation in patients who are receiving ICD shocks. However, when we take up these high-risk patients, there are few predictors that these patients might require hemodynamic support during catheter ablation. And the total score can go up to 35. And the scores more than 9, they predict the chances of need for a mechanical circulatory support. So whenever we are planning for a high-risk catheter ablation in a patient with significant LV dysfunction, we should always prepare for or plan for hemodynamic support, maybe IABP that is available in most of our centers. IABP at least we should try to have cover up. So like presence of COPD, age, ischemic cardiomyopathy, NYH class 3 or 4, ejection fraction less than 25%, history of VT storm, and diabetes mellitus. So these are the predictors that have been developed by the Santengali group. I would like to show 1 or 2 cases of mine. So this was a patient who had ischemic cardiomyopathy who was post CRTD and present with multiple shocks, some 13 shocks in 2-3 days, and monomorphic VT was inducible in the cath lab. There was some, I went for an epicardial also in this case because there was some literature that epicardial endoepicardial mapping may increase the long-term outcome. And after we did the endo and epicardial mapping, so this was the baseline echo showing severe LV dysfunction. We also did ICE because the LV was very dilated. So it was not sure that whether we are actually touching the areas or we are going for spuriously low voltage areas. And then where there was isochronal crowding, we did ablate. And this case was done in March 2020. And so far patient had only one, after that patient had received 1 shock and 1 anti-tachycardia pacing. So, he is relatively now stable and happy with the result. This was another case, again, presented with electrical storm, multiple shocks, case of ARVC. And like the classical ARVC, what we see is that the QRS duration in the V1 to V3 is longer than the QRS duration in V4 to V6. So it was a classical case of ARVC, MRI proven, RARV dilated, post ICD, presented with multiple shocks. And here also we did epicardial, because ARVC we know is that epicardial to endocardial disease. Most of the substrate is epicardial, and this disease was fairly advanced disease because structural change was there. There was complete RBBB, which are predictors of pretty advanced substrate in these cases. And we found that there was basal substrate. I would like to show the voltage. So these are all the delayed potentials in the endocardial areas, and then delayed potentials in the epicardial mapping. Also, we found very good, nice, discrete potentials here, and we targeted all these areas. The propagation map was also correlating with these findings. So finally, we ablated, and he is now shock-free for last 1 year. Patient is the drug therapy includes metoprolol 100 mg twice daily, but patient is now shock-free for last 1 year, so he is happy. So these are the final ablation lesions. This was a very interesting case. Like I was saying, the idiopathic here. This is a patient, a 21-year-old male who had early repolarization syndrome. So there's a J point elevation part. So this is now called J-wave syndrome. So there is a J point elevation, and he presented with VF. Multiple episodes of VF. He was very lucky to reach the hospital the first time. And once we diagnosed him as a idiopathic VF, actually ICD was implanted. After that, multiple antiarrhythmic drugs were tried. However, he was getting regular ICD shocks. So I discussed this case with many authorities also. And then I thought that everybody advised that a cardiac MRI was normal. There was no scar, nothing on the cardiac MRI. So I took up the case, and endocardial, epicardial, both sides we tried to map, and we found some, I'll show, some delayed potentials were there, not like the ARVC delayed potentials, but there was some lava, local abnormal ventricular activations. So I tried to target all those areas. These are the epicardial areas, some basal border zones. However, after ablation, the patient, the number of shocks, according to the patient, the number of shocks have come down. Even previously, he was getting an average of 4 or 5 shocks in a month. Now he gets 1 or 2 shocks, and I mean, in a way, he is also accustomed to his shock. But his battery needs replacement. In 2 years, his battery drained out actually. So this is the latest ECG. When we compared with it with the initial ECG, I don't find these clear humps, the J points. However, there is ST elevation is still there. I don't know how he will do in the long term. I have to see. So combining all these types of cardiac problems in the electrical storm patients, the assuming medication, hemodynamic support, and there is no reversible factor, the chances of success according to the etiology. If it is a non-ischemic cardiomyopathy, shock, prior ablations, patient presents with VT or polymorphic VT or VF, then neural modulation has the highest role in these cases. Then stereotactic body radiation and ablation is less important. If the patient presents with ischemic cardiomyopathy, no revascularization, monomorphic VT, then ablation is very important. Stereotactic body radiation is important. Then neural modulation is less contributory in these cases. In patients with ischemic cardiomyopathy, no revascularization who present with VT, who present with VF or polymorphic VT, probably stereotactic radiation is more efficacious in this, and then neural modulation and ablation. In patients who are already on LVADs, who are non-ischemic cardiomyopathy, history of prior ablation, and monomorphic VT, their stereotactic radiations, neural modulation, and ablations. So to summarize everything, when a patient presents with electrical storm, we should try to resuscitate the patient, then initial try to correct, support, go for a drug therapy, then go for therapy escalation in terms of neural modulation and catheter ablation whenever feasible. Thank you.